Okay, I have a quick notice to make here. We are going to have two closed sessions today. The first closed session will be with attorney. Is someone here, Linda, for BBK?
No, it's just the letter, and it's what you have right now.
Oh, okay, that can be the second one. The first closed session will be with Arts firm, Renee Public Health firm. And that would be a closed session with only the board members present. And then the second closed session will be, we discuss a litigation matter, and Linda will be present along with the board members. We are going to go out of order. I will have to call to order the pledge, and then the public comment period, and we'll go into a closed session so that the attorneys can get started on it. So I'll call the meeting to order, and we all stand for the pledge of allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Before we do the public comment period, I just have a quick statement I want to read here. And I'm going to read this because I get kind of choked up sometimes. On behalf of the Board of Directors of Seneca Healthcare District, I would like to extend all of our sincerest condolences to Aaron and the Seandale family for the loss of their matriarch, Dana Seandale. And I hope the family realizes how much we all appreciate the years of service she has given to this district. With that, we'll open to the public comment period. Yes?
Nancy Foote. I have two questions. One is, how and when are you going to decide on a replacement for Dana? That's one question. And the second question is, the community would like to know the result, if any, of this private investigation. Since we're all dragged into it on Facebook, we need to know what went on. Thank you.
The mechanism for choosing a replacement for Dana is clearly outlined in the state law statutes, and we have posted an opening, and right now anybody that's interested in applying for the position can send a letter to Joanne. The board has not yet decided, since this is a recent event, has not decided yet when we're going to make the appointment. If you submit a letter to Joanne, it should include your qualifications, what you think you have to offer the district, and why you would like to apply for the position.
As to the other question,
The second question is, at the present time, that is still a matter of closed session, and we're not ready to open it up to the public at this time.
do you have a date in which you might do so?
No, I don't, because we're only going to get the report today. Anyone else want to make a comment? Shirley?
Yeah, on your human resource person, was that job appointed in-house or outside, and what were the qualifications for that job?
Well, I would defer that to Linda.
The human resources, when we put that position up, it was flown internally, and then it was also flown outside. It was flown, we put it in the newspaper. We also had a search firm looking, and we had a couple of candidates. We interviewed candidates.
Okay, and what were the requirements for it? Because I heard a lot of negative things about the human resource.
You know, I don't have it off the top of my head. I can get you the job description, and that'll give you the qualifications.
All right, next board meeting will be fine.
Okay.
Anyone else? Okay, then I would request that everyone leave so we can have our closed session. Move on with the meeting. I will announce that the board met in closed session, and at this time there's no reportable action. I do want to say, though, that the board is taking the personnel matter very seriously, and for that reason, we are scheduling a special session for November the 15th, at which time we will be taking action on the report that we received tonight, which is still privileged, attorney-client privileged. With that, I would like to make note for the minutes that the board members in attendance are Ken Crandall, myself, and Jerry Nielsen. And I would be willing to accept a motion to approve the minutes of the September 24th meeting.
Second.
All in favor, Jerry?
Aye.
Ken?
Aye.
And I vote aye. Dana, do you want to give a report from the medical staff?
Yeah.
Oh, let me just say one thing. We will be having the second closed session meeting at the end, because there was some discussion amongst the board members as to how to follow the Brown Act. And so we decided to split them up.
Okay, so the old business was credentialing for Dr. Cooper. As I understand it, did Dr. Mellon talk to you?
Yes.
Dr. Wells, okay. And it was his opinion as the head of the ER emergency department that Dr. Cooper was A-okay.
He was proctored by Dr.
Yeah.
Mellon, and also, for some reason, there was I don't want to say a rumor, but there was an idea going around that Dr. Cooper hadn't worked in ER for like 20 years or something. The fact is, he worked at Folsom just 5 years ago? 5 years ago. It hasn't been 20 years.
And does this require, I don't know why I'm asking, but does it require action of any kind?
I think the board has to approve his ED privileges.
Yeah.
I thought we already
No, it was kind of provisional because we wanted to have him evaluated, and Dr. Mellon worked with him. Anyway, why don't we have a motion now to approve him?
So the med staff already approved?
Yes.
I'll make a motion.
Ken?
Second.
Okay, all in favor? Jerry?
Aye.
Ken?
Aye.
And I vote aye.
All right, and then the policies for your pleasure are these, and some of these are revised and some are new.
Can we distinguish which ones are revised and which ones are new?
It says on the...
Can we distinguish between which ones are?
Yes, you can, and they are, the first one was written by Casey Broussard, and,
Oh, I'm sorry, I see the revision dates here, so
Yeah.
that's my question. Sorry.
It's on the agenda, Mr. Action.
Okay, thank you.
so the smart anti-wander alarm is new, crash cart is revised, daily building inspection, medical gases during daily inspection, which is new, and then a new policy for the semi-annual inspection of fire alarm system, dialer, battery. And they're all straightforward.
Okay.
I'll
So,
make a motion to approve.
Second?
all in favor? Jerry?
Aye.
Ken?
Aye.
And I vote aye.
And then apparently, the conflict of interest policy is being deferred to some as yet determined future date.
Is somebody working on that? What is the status of that?
Well, I think that was Sadie was working on that.
Okay,
I've been working with Sadie a little bit on that.
okay.
So I guess I'm just unclear. It just, you're continuing to work on this.
Yes, we already have in our code of conduct for conflict of interest. We're trying to gear it so it maps that, but maybe there's a few changes that need to be made, so we're trying to figure out.
Okay, so it was just still in the works, is it?
Yeah.
Okay.
Steve?
Okay, we're under tab C. And you guys should have had the materials since last Friday. Dr. Walls and I met with Rich Rydell as the advisory group or whatever we are to review the information. So I'll try and keep this brief. I think that the financials speak for themselves. The one underlying thing is that our utilization is down throughout the hospital. Outpatient, pretty much across the board, physical therapy, one of the few areas that Steve doesn't have much variance in his practice. It stays busy pretty much all the time, and actually could probably keep someone else a little busy too if we could find that individual. But everything else was down. We looked, it's down to October of 18. We had some discussion in the meeting with Dr. Walls and Rich about adequacy of providers. I think that's not an issue. I think we now have an adequate supply of providers. We looked at the October numbers. The clinic is up in comparison to September.
The October numbers mean the number of
number of clinic visits. We looked at clinic visits and ED visits, emergency department visits, and the clinic is up. It's up pretty good. It's going to be over 1,000 visits. We're just barely over 900 visits this month, and the emergency department visits are down quite substantially. One of the lowest numbers that we've had back a couple years. We're going to have something in the range of 160 visits, and that's right around our lowest ever. So what that says to me, anyway, is that finally, I guess, if you will, is that people are utilizing the clinic for their primary care, which is a fantastic thing. And it appears that, based upon our numbers, that we now have an adequate number of providers, all things considered, I guess, that to meet at least this current demand. We projected based upon historical numbers when we had all full-time providers, more or less, that there seems to be a larger demand. The Whitley report suggested there would be a larger demand, but maybe September, October is not one of our better months to test our demand. So,
is that a historic cycle low point?
Yeah, it's one of them. It's interesting. February was another one, I guess, because of 28 days, but I didn't think of that. I mean, the number of clinic days you have, but January, February was surprisingly was a lower time too. So, yeah, I don't know. The inpatient was at 21 inpatient acute days. Swing is back in services. We're having swing patients again. We had 29. Looking at October, looks like we're going to have 21 acute days. Might be plus or minus there. It's pulling off the census sheets. And swing bed days are at, again, plus or minus 25. So fairly similar to September. As you can see, the budget for inpatient days was 35, and the budget for swing days was 38. So we're a little below that in relation to budget. The skilled nursing remains, or the long-term care units remains full. So the good news, to me it is anyway, and I know to Karen and nursing leadership and certainly everyone, Jim and others that are involved in the recruiting of staff, that we had a positive variance in expenses. We actually had a net positive variance in labor costs, and our labor FTEs are right around the budget. You can see we're a little bit over on FTEs, but it was interesting. Our average hourly wage is down from 33, a budget of 33.1 to 31.05. So Other expenses, all kind of in line. When we looked a little closer, we saw that we had put September's electric bill was expensed to August. And so it was kind of masked a little bit by the fact that our cost for internet access has gone down substantially. We signed a new agreement with the company that's been providing our internet access for a much lower amount, but we won't be participating, at least this year, in the USAC program to get full reimbursement. We will get half reimbursement from the state. Everything else fell in line. Cash came down, unrestricted days of cash declined a little bit just due to the loss. The accounts receivable, from a dollar perspective, was essentially unchanged with a $4,000 increase, and gross accounts receivable days ticked up a little bit, and I guess we can talk about that in the HRG. There was a question at the last meeting about bad debt expense, and as you can see, if you look at page 2 and that first column on from the left is our actual for the month, and right next to number 12 there on the far left is bad debt. And so, excuse me, for the month of September, our bad debt expense was $14,000, 928, just under 15,000 versus a budget of just over 78. So a positive variance for 63,000. Year to date, we have a positive variance of 2,589, but our gross revenue is down, so that bad debt as a percent is a little high. Right now, year to date, September, we're at 3.26%. Budget is 3.17. Last year was 3.18. So that percentage variance translates to about, off of revenues, about a $6,000 variance. We looked at it, we haven't seen any abnormal write-offs. It's just really the way we calculate our reserve. We take a percentage of third-party commercial insurance type accounts receivable, and when it ages out a certain day, we put a little bit of a bad debt reserve on it. The idea being is that there's going to be some patient responsibility in that, and that if we don't have it sitting in the private pay, then we don't see it. But we can also have accounts receivable age out, and then we collect it all, and then we go over reserves. So we can go back and revisit this, but the real story is that now the quarter to date, we're right in line pretty much on a percentage basis and a dollar basis. So we'll keep an eye on it, and if we need to do something further, we will.
Steve, on your summary there on page 1, $280,000 net loss for one month. Is that a pretty much all-time high loss? I mean, I just don't remember seeing numbers that large before.
Look at that. That's probably up there, because we might have had one last year.
Okay.
But I will look and see if that's it. And we talked about this when we met with Dr. Walls and Rich, and we know that the patient demand's out there. This is just a down. It's across the board. I mean, the utilization of the hospital is just down. If somehow this turns out to be the reality, that this is our utilization, then we probably are going to have to address something on the expense side.
So is this just utilization lagging behind new staff?
Now, when you say new staff, are you talking about
We
providers?
have new providers here, new providers here, and community awareness about them, comfort level with them, all that stuff. Is that still catching up to the number of providers and filling out their schedules, awareness that they're here, all of those things?
I think we're looking at, there's some more promotion we certainly can do, but Dr. Cooper actually was seeing more patients when he first showed up, and his patient volume has gone down. Teresa Nielsen, of course, assumed, if you will, she assumed first Dr. Suarez and then assumed some from Dr. Salehi as did Dr. Cooper. But Teresa's been here for a year or so, and her practice has been, her patient volume has been pretty steady. So we may have lost some of Dr. Salehi's patients. I don't know, I guess we could go deep into that and see if.
Well, one of the things that have been happening from the walk-in clinic is when patients are coming into the walk-in clinic and they don't have a provider, we're referring them to Dr. Cooper and to Teresa right now. Whereas before we didn't have anybody to refer them to, now we are. So that's been helpful.
But I think I heard you say something about the state reimbursing us for something when you were talking about the internet. I didn't quite catch what that was.
Yeah, there's a program, the USAC, which is the federal program. I'm not quite sure what it stands for. They would reimburse us 100% of our internet access costs, but their program is subject to funding. They're horribly delayed. The state has a program where same kind of idea, but they'll only reimburse half of the cost.
Okay.
So.
And are there stipulations in how do we qualify for that, or just automatically?
I believe we automatically qualify. I don't know if it is here, but
I'm just curious if that sounds like a good idea.
yeah. Okay, that's really all I have, unless you all had some questions or off the materials or what I said.
No, I don't have any.
Oh, sorry, I have one last question.
Yeah.
Are we starting the audit process yet?
Okay, we actually have completed all of his field work. He sent a draft of the audit to us, or to me this week. He's done, with the exception of any amount due to from Medicare or Medi-Cal from the cost report. He would like to, originally, he was hoping that we would move our board meeting to the week before Thanksgiving. But when it was moved to the 26th, he is unavailable that week. So we have a couple options here. We could have him come out that week before and just have a special meeting to present the audit, whatever else we might want to do. It sounds like we could have 4 board meetings or 3 board meetings in the month. And then it'd be a public meeting, and then either approve it with a full board there or take it to the board meeting the following week. Or we just do it in December, and there's no harm in that.
Have you seen anything that's out of the ordinary, something that works so far?
He had no adjustments that he's made me aware of that he generated himself. He took all of our adjustments and put them in. We had some changes from June, and I'll map you guys to that from the June that you all approved. That we made some changes when we cleaned up the books. I think it's going to go plus and minus both ways, and very little impact to the bottom line, as I recall. So I haven't seen any other reports or communications that he would produce. So it's kind of up to you guys. I don't see a problem with doing December. If you want to do it the week before with him, and then either approve it there if you all have a quorum, or have you guys review it, whether it's the advisory group, finance advisory group, and then take it to the full board with their recommendation. doesn't matter.
Do you have any strong feelings one way or the
I
other?
think that's a pretty good suggestion there, have the advisory group look at it and then bring it back to the board for recommendation.
Is that okay with you? Okay. Anything else on the financials? The capital request?
There's no requests or no changes to what's been previously reported. Linda Wagner and Karen will be reporting on some of the projects that are in progress though.
Okay. And then the HRG?
Okay. They're kind of treading water, if you will. It's not getting better, but it's not getting worse. Pursuant to your direction, made contact with CPSI, who has a revenue cycle entity called TrueBridge, where they do what HRG does. We've asked them to make a proposal. They came out here, they made a presentation to us. It looks good. The numbers actually look better. However, we asked for recommendations, and we asked for a hospital that in California, just like us. And one of the first things they said is they don't have a California hospital that has a nursing home, which is a bit troublesome to us. Their solution to that is they just hire somebody. A lot of what they do, they do their billing and their revenue cycle functions from a service center in Mobile, Alabama, and then I think they have a couple service centers, I don't know, Texas, Louisiana or something, more in the middle of the U.S. They don't have anything out west right now. But what they do is they contract with people to work remotely. So a lot of the work is done, basically from people's homes or from their offices or wherever they work. So they just said, we just hire someone. So that's fine, and I'm sure they will. The big problem is that our number one issue with HRG is their depth of human resources. And when someone leaves, then they have to train someone, find someone, and I think certainly in the case of the nursing home, we're looking at the same thing potentially with TrueBridge, and the nursing home is just a really nice cash flow for us. That money just comes in, and once you get it down and know what you're doing, it's fairly, I don't want to say easy money, but it's labor, not labor intense to do. Problem is that Medi-Cal beneficiaries have a share of cost, and we have to make sure that gets considered, that we get that from the beneficiary, the right numbers on the bill. It can cause all kinds of complications, and it has. So that's a concern. The other concern is that the client the facility, California hospital that they referred us to, they haven't been able to get their AR days under 60. So went back to them, we said, can you give us a reference for a hospital? I don't care where it is. Has to be critical access, has to be small. I don't want you giving me a big hospital with lots of resources. And they gave us that's in your best practices, 45 days. And they gave a hospital that had some unique differences that keep their AR days down. So that wasn't great. The individuals spoke, their CFO spoke very well of TrueBridge, so that was positive. I think she meant it. But I think that the other problem is that a big key or consideration for moving to TrueBridge is that they will bring revenue cycle tools. They will bring automation to us. We'll be able to do things instead of so labor or paper intensive. That we'll be able to do things in a more efficient manner and manage the revenue cycle as opposed to doing road duties. The hospital that they gave us the reference for isn't using them. So we have to have a reference from a hospital that's doing best practices, that's using these tools.
Do you know why that hospital is not using
They
it?
just haven't done it.
They haven't done it yet.
So, they'd like to, but they just haven't done it. So we need to talk to them about that. And then the final complication in the whole thing, or the thing to consider, if you will, is that CPSI now has a business model that if you do this business office outsourcing that we're proposing, that they will give you all of their software solutions for no charge, and how they'll get their money is they'll take a percentage of the collections they get from you as the way that they get their fees out of it. And this could be a really good thing if we were thinking about expanding our utilization of CPSI, which is really a question at this point, especially when we're considering a potential $400,000 or so investment in an emergency department solution. So they ran the numbers for that too, and I think it's going to be pretty close to a small savings, if anything, on what we're doing now, as far as what we're paying them for their system. The business office outsourcing is definitely going to be under what we're paying now. And they said that price would hold if we just went for the business office outsourcing, that we would get that. It's not contingent upon us taking the whole deal. So we'll see if he really meant that. Now, what this potentially gives us the opportunity to do is to now go back to HRG and open up their contract and say, maybe not lower their fee, but put some really significant penalties in there if they don't produce, to the tune of getting it down to, if they don't produce, getting it down to what CPSI would charge us. So,
Do we know if the other district hospitals, how they handle this process?
most that I know, or at least around this area, are fortunate enough to have in-house staff to be able to do it. And that's certainly something we'd want to consider at some point in time, but
I think the hospital had trouble when it was in-house too.
because when we lose people here, which happens in all departments in all areas, and we lose them in the business office, we're in deep stuff. So I don't know. So we need to make a decision no later than December. So we'll push on with seeing if they can give us a reference that is using the tool, and we can kind of get a better thing and start the discussions with HRG about whether or not they'd be willing to look at their contract.
Yeah, if nothing else, you have a little bit of leverage.
And a lot. So that's where we stand with that.
Thank you. Any other questions for Steve? And I presume there's nothing on governance education?
Actually, I do have something that came in. The 2020 ACHD Leadership Academy schedule is for February 20th and 21st in 2020 in Sacramento. So they're giving us plenty of lead time to...
What are the dates again?
It's February 20th and 21st.
You should have it in the very
And
front.
it's in... That's them, it's just... Yeah, because I just got this one.
Dr. Walsh, we need to vote to accept the financials.
Oh, yeah, we can. But what if we don't want to accept them? I don't like that big loss. Could I have a motion to accept the financial report from Steve?
I'll move that we accept the report.
And-
I'll second.
Okay, all in favor, Jerry?
Aye.
Ken?
Aye.
Ken, I'll vote aye. I'm sorry, Joanne, what did you say there was?
No, I put a flyer in the front, but it's not the flyer.
Oh, no, that's the mental health one? Yeah.
Sorry about that.
Okay, committees, anything to report on the bylaws committee?
No, I figured we ought to defer it again since they we had so much else to go through today.
And strategic planning,
I have the update on the land purchase agreement. It came back from our attorneys, so I've sent it to Steve and Lance and myself, and we're doing that last final review before we send it off to Collins, to their attorneys. Then we met with Aspen, and they will be sending us the final report for the master planning. We had to give them some more information. We also met with Whipley and gave them some more information, and they're going to be adjusting their final report. So we should be getting those reports within the next couple of weeks.
so this process was started before I was on the board. I'm just curious on the land for anticipated new hospital build, what other parcels were looked at?
We looked at the one, and then we checked other parcels throughout downtown Chester area, I guess best way to put it, and there was not any other parcels that had the amount of acreage that we could use. They threw back out that one on the corner out there, Four Corners, and that wasn't within the area where we wanted to use.
So was the fact that this is adjacent to the clinic, was that
It's very
influencing?
strong influence.
Okay.
Are you questioning that?
Well, I have somebody who owns about 60 acres of land fronting on Highway 36 that was wondering why he was never contacted. He thought he could sell 15 or 20 acres to the hospital.
Where is that?
Just outside of town before the cemetery. He just asked me and I couldn't answer his question.
I don't remember hearing anything about it ever.
Well, people probably didn't even know it was there. I don't think he was advertising it for
I
sale.
don't remember hearing about any other lots under consideration.
That's fine, I just was curious. Okay, CEO report?
Dr. Mazazi, I've been in contact with her on and off for the past couple of weeks, and she's got the offer letter and the proposal that was within the authority. She's looking at it. She wants to send back a counter proposal to me, which she's supposed to get to me tomorrow. So she's very excited about coming up here. She wants to be here. She's looking more towards the ER than she is clinic, but she's investigating everything. We did a first phone call with Dr. Vargas, and he was not a really good candidate. He was looking for a faster paced ER, and he was also a candidate that didn't have a California license. Then Dr. Singh, we did a first interview with him. He's the one that will be graduating in June of 2020. He will set up now the second set and round of interviews where he'll talk with the physicians and then maybe do an on-site if it still remains positive. Dr. Cullen is the resident that's from Shasta College. He wants to come in and do some ED shifts with us. So we'll be setting up some interviews to make sure he's somebody we want here. So those are the updates for the physicians. Then the CT ramp update, as you probably saw, if you've seen out there, it's in process. Lance has been working on it, and he anticipates it being done in the next couple of weeks. And then I'm going to jump down to the SNF patio. After that CT ramp's done, then he will be working on the skilled nursing patio. The follow-up on the driving the vans for community members to choir practice. When I checked with Beta, there's a lot of restrictions for doing that because they're not going to be Seneca patients. It's a whole different matter if they were patients we were transporting versus community members we're transporting to a non-district function.
Saying that we cannot do that?
Well, we can, but we have to jump through a lot of hoops and then do a different policy, a liability policy and a different driver policy, as well as we would have to have a driver that has a chauffeur's permit because we weren't moving them from Seneca Healthcare District, from a patient to their home. We're going from somebody's home to somebody's social activity in the community. So that's more of a chauffeur, Uber, cab type thing versus what we would be doing from the facility.
So are we looking at doing those things, or what are we?
Well, and that's, what I'd ask them is, what is the cost for the liability insurance? I didn't even get into trying to find somebody with a chauffeur's licensed to do all that. I needed to look at the cost first, so they're trying to put that together. I don't even have a quote. They wanted to know how many times a month we would be doing that. So I had to guess. So yes, we'll see if it's a quote that's something that we want to look at. Then there's an OSHPOD meeting next week that Linda McCurdy and I will be going to about, it's just a meeting to discuss all the different and new OSHPOD rules. Then you also, was in the front of your packet, we received the information from AMI about the Mental Health Services Act and the meeting that they're going to have in Chester on November 7th from 5 to 6 at the Wellness Center. So we've got that. And then the last thing I wanted to say is that Aaron Sendell had called me and talked to me. You know, we know the services at the cemetery are at 1 for Dana, and then there's another celebration of life at 3 at the Lake Almanor Country Club Clubhouse. What Aaron had requested is that if there's any donations, they want the donations to go to the Seneca Healthcare District Auxiliary. So we need to make sure that that's out there.
Can we go back to the Aspen Street plan for a second? So you guys met with them again after?
No, we met and then they called us back with some questions.
Okay, good. So Dr. Walls, that meeting with the architects, there weren't any physicians there. And they were talking about requirements for a new facility. So I don't know if, you probably need to get someone from medical staff involved in that.
Yeah, wonder where
At
we could
least-
find one of
at
those.
least one. Well, I'm not saying it
We
has to
can-
be you necessarily, I'm
So
just
it's going to
saying.
either be myself or Dana.
Yeah,
We could discuss it at the medical staff meeting.
Okay.
Yeah, because they were talking about requirements for the new building, you know, where they wanted things located, what types of rooms, all that kind of thing, so I think it's important.
We did invite the medical staff to that meeting.
Well, they
So.
were probably some patients, so, yeah, it was a, yeah.
Thank you.
Okay. Departments, let's see, is Casey here? No?
Emergency retreat.
Sadie, not here? Oh, no, I'm sorry.
Yeah, it says no
You're
report.
too efficient for me. No reports. Okay. Karen, do you have a report?
I have a few things. I just wanted to give an update on the lab remodel. It's coming along, and it looks like it's going to be completed on time. We're thinking somewhere between probably the 7th and the 10th of November. It's going to be exciting and great. It's looking real good right now. They've got everything out, and they're just getting ready to start putting everything, you know, the flooring and the cabinets in.
I love to see it when it's done.
Oh, yeah, it's going to be great. The X-ray department, the CR and the DR is up and running. We're excited about that. In case one goes down, we've got the other one to back us up. The new X-ray table is installed, and it's amazing. I don't know if that means much to you guys, but just to have to be able to adjust that table low to the ground so we can take on an elderly person, we can move someone over a lot easier. It's just a really nice feature to have, and we have that now. One of our X-ray techs has resigned, and we're in the process of looking for a temp until we hire a replacement. And I have a little bit of a report for care coordination. Casey, Heather, and myself attended the Prime Bureau meeting this week. We were there on Tuesday and Wednesday and got some information about what's coming in the near future. And it was a pretty interesting meeting. They talked about Cal AIM, if you want to get on their site and look at that. It's a pretty interesting process of what they're going to be starting up here pretty soon. They've also finalized the Prime Grant DY 13-year ending report ending. We've overperformed in 3 of the 5 metrics. We overperformed in MedRex within 30 days, MedRex on discharge, and notification of primary care on admit. And what we didn't meet was the HCAHPS and the 30-day readmits. We don't have a lot of choice on this 30-day readmits because it's hard to control because a lot of the patients are using the ER for their primary care. The HCAHPS, there's really no middle ground. You have to have the highest rating to even
score and be considered that you passed it. So to help improve the scores, the girls have increased patient awareness to complete the survey by putting in a sample in their discharge package. So they have that with them and then kind of go over it with them when they're in the rooms and kind of show them what's going to be coming. And then we get a self-addressed envelope. And then one of the complaints a couple of months ago was that it's kind of noisy at night, so they've implemented those packets where they have some earplugs and they have an eye mask, and so it won't be quite so noisy at night. So we're trying to improve, to bring those scores up. That's it for me.
Okay, thank you. Let's see, Ann?
I think the agenda kind of said it all. We received an incentive award from Athens Blue Cross for exceeding HEDIS measures in 2018 over our base score in 2017. So I think there was 3 measures that we were above and beyond. I don't remember off the top of my head. I'm sorry, I should have brought that with me. But so we got a nice $9,000 check from that Steve signed for.
The board members, Ken, do you understand what that is?
No, but I like $9,000.
Could you just explain?
Yeah, so the HEDIS measures are specifically driven through Medi-Cal, CMS, and they are looking at specific preventative measures that we're doing, making sure people are coming in yearly for their well physicals. We're immunizing people. Those with diabetes are coming in for the HbA1c testing, podiatry testing, those kind of things. So we have a raw score of the amount of patients that we were able to see and complete all of those preventative cares in 2017, and then we improved the number of patients that we saw and had compliant in 2018. And so because of that improvement in those areas, we were awarded money. You get so much for 5%, and then if you go over to 15%, you get that much more, and you can just keep adding it up. So I think the clinic staff and physicians did a fabulous job getting the patients in and seeing and cared for. Dr. Walsh, I had one other thing about the influenza. We're getting a shipment tomorrow,
Right.
and we're also getting another one on the 20th.
Okay.
So we should have enough by the 20th for
Okay.
everybody.
And that is something that they've been really pushing, is the immunization updating on all the office visits anymore. Okay, and nothing from IT, and HR has a written report. Does anybody have any questions on that? We have nothing from the consent agenda. And the next month's agenda, items to be added, not much came up today, Joanne.
I have a little bit here, we'll see. Conflict of interest, we'll be planning to bring that to the next one.
We should be able to.
Okay.
Yeah.
And the HR job description was already given to Shirley, so we don't need to put that on.
Okay.
And, what else did I have? Steve is going to check on the internet reimbursement, is that correct, Steve? That sounds right. And I also, Vans to the chiropractic, to come back with more information on the cost, their cost.
Okay.
I think that's all I have.
And then the CEO annual performance evaluation, I think that's overdue already, isn't it?
Yeah, do you want that on,
I think tentatively we can put that on. So we're going to have another closed session pertaining to potential litigation. And Linda, you'll please stay for this one. Back in open session, we had a closed session meeting to discuss potential litigation, and there's no reportable action from that meeting. And there's no other business. There will be a special board meeting November 15th. The next regularly scheduled meeting will be November 26th, which is a Tuesday, and it will be at 3 o'clock, same place.
Number 15 at 3:30?
Oh, and the special meeting is at 3:30, you're correct. Meeting's adjourned.